Hello, today we're going to be talking about opioid overdose within adults. This will be an unfolding case study presented by me, Anna, and this is for my class, Nursing 213, as my capstone project. Day 1, admission. Patient is white, female, 26 years old, admitted with opioid codeine overdose. Patient was found on the floor in a restaurant's bathroom at 1900, which is 7 p.m. The waiter found the victim and immediately called 911. Patient is unresponsive. Patient presentation: cold, clammy skin, slow, shallow breathing with periods of apnea, which means no breath sounds at all, bluish lips and fingernails, confusion in pinpoint pupils. Nursing care plan: immediately airway assessment and naloxone administration, which is a counteract to opioids. Observation and patient interview, physical exam, diagnostic tests, promote communication, limit setting and boundary violation, promote adequate nutrition and hydration, and promote participation in treatment, which is very important that the patient is compliant. Day 1, question 1. The nurse is caring for a newly admitted patient with suspected drug overdose. Which of the following confirms this diagnosis? The patient is 1. Hot and diaphoretic, unresponsive, feverish, hyperventilating. That creates an immediate risk for 2. Organ failure, respiratory distress, infection, brain damage. Question 1, answer and rationale. Answer is 2 and 2. That is, the patient is unresponsive. That creates an immediate risk for respiratory distress. The rationale is an overdose patient is cold and clammy, not feverish, with slow, shallow respirations. That is great risk for respiratory arrest. Brain damage is a long-term complication on drug abuse. Day 1, question 2. A nurse is assessing a patient after a potential drug overdose. What are the priority actions to treat an unresponsive patient? Select 2 answers according to their priority. 1. Take blood pressure. 2. Take off the clothes. 3. Administer naloxone. 4. Put the patient in a sitting position. 5. Administer oxygen. And 6. Administer diazepam. Question 2, answer and rationale. Answer is 5 and 3. Rationale: according to the ABC priority framework, take care of the airways, and breathing will be the first action, followed by naloxone administration. Also, the nurse should assess the patient for acute injuries and address them. Day 1, question 3. Who is at greatest risk for opioid overdose? Select 3 answers. 1. Chronic pain patients. 2. Adolescents with unstable income. 3. Elderly people who live alone. 4. Living in the outskirts. 5. Athletes who exercise regularly. And 6. Children of drug-addicted parents. Answer and rationale. Answer is 1, 2, and 6. Rationale: chronic pain puts people at risk for painkiller overuse. Adolescents with unstable income may experience anxiety and depression that leads to drug abuse. Children of drug-addicted parents are most at risk to copy unhealthy behavior. Living alone in the outskirts and exercising does not put you at risk for drug abuse. Day 2. After administering naloxone and IV fluids, patient presentation: alert to person and remembers her name, follows commands, pale but no more blue lips and fingernails, anxious, nausea and vomiting, headaches, body aches, rapid heart rate, diaphoretic, abdominal cramps, irritability. Day 2, lab and diagnostics. Codeine blood concentration 400 milligrams per deciliter, sodium 140, potassium 2.5, glucose 230, non-fasting, enzyme immunoassay, urine positive for opioids, chest x-ray, no findings, ECG, bradycardia, presence of a P wave, flattened T wave, occasional U wave. Vital signs: heart rate 60, which is already closer to the regular heart rate, blood pressure 100/75, respiration rate is 12, again that's an improvement. Oxygen saturation is 95 on room air, temperature 97.7, breath sounds slow, deep and regular. Again, it looks like the patient is improving. Opioid use disorder screen. It's a useful tool to screen patients and understand if they are opioid addicted. So there are 6 questions. Question 1 is, do you ever use more of your medication, take a higher dose than prescribed? Yes or no? Do you ever use your medication more often, shorten between doses? These are patients' answers. The patient said yes. Number 3, do you ever need early refills for your pain medications? No. 4, do you ever feel high or buzzed after taking your medication? The answer was no. Number 5 is, do you ever take your medication because you are sad or upset? The answer was yes. And number 6 is, have you ever gone to multiple physicians seeking more medication? The answer was yes. Opioid use disorder screen results. Even if the patient answers only 2 questions positively, that means 2 yes answers, indicate a positive screen and a possible diagnosis for opioid use disorder. There are several screenings. They will be performed to determine the patient's addiction. Hair probe, traces of codeine, CBC, drug concentration in blood, electrolytes to detect imbalance as an underlying cause for dysrhythmias, renal panel to assess kidney function, liver panel to assess liver function, hepatitis screen, especially with Hep B and C, are linked to opioid abuse, STI panel, including HIV, to rule out those diseases, urine drug screen, how much of the drug is still in the body, ABGs, determine respiratory acidosis is a common finding as opioids cause respiratory depression. Day 2, question 1. What are the initial withdrawal symptoms of codeine addiction? Select 4 answers. Lethargy, hypertension, lacrimation, diaphoresis, sleepiness, nausea, hyperactivity. Answer 1. Question 1, answer and rationale. The answers are 1, 2, 5, and 7. Codeine withdrawal usually presents in irritability, not lethargy. Hypotension, not hypertension. Difficulty sleeping, not sleepiness. And tiredness, but not hyperactivity. The other symptoms are common in codeine withdrawal, not addiction. Day 2, question 2. Which lab requires immediate attention? Sodium 140, indicated or not indicated. Potassium 2.5, glucose 240, magnesium 1.5. Day 2, question 2. Answer. Sodium 140 is not indicated, potassium 2.5 indicated, glucose 240 not indicated, and magnesium 0.5 indicated. And the question 2, answer in rational. Potassium of 2.5 requires immediate follow-up as it may cause serious dysrhythmias. Potassium range is 3.5 to 5. Magnesium is usually low with opioid use. Range 1.5 and 2.5. Glucose is a bit elevated, but since it is non-fasting glucose, it may be experienced with drug overdose. Other values are within the normal range. Day 2, question 3. The ECG shows the presence of a P wave, flattened T waves, QRS complex, and occasional U waves on the client's cardiac monitor. The nurse should expect 1. Hypokalemia, hyperkalemia, hypercalcemia because of flattened T wave and U wave, P wave, or QRS complex. Question 3, answer and rationale. The answer is 1 and 4. Hypokalemia indicates flattened T waves and occasional U wave on the ECG because of impaired repolarization. This arrhythmia may be life-threatening and requires immediate attention. Day 3, patient presentation. Patient is alert and oriented ×4, some drowsiness, IV fluids and electrolytes inducing. Patient shows some edema. Screenings and tests diagnose long-term opioid use via hair probe. Vital signs and lab values. Hair probe traces of codeine, CBC, elevated WBCs, RBCs, and hematocrit. Electrolytes, hyperkalemia, renal panel BUN elevated, creatinine normal range, liver panel ALT and AST elevated, hepatitis screening A, B, and C negative, STI including HIV negative, and urine drug screening negative. This is a part of a long study which shows how opioid use reflects in your blood. So blood work results. Studies confirm blood values outside the normal range are common in patients with opioid use disorder. Like this part of a study shows a raised AST and ALT in most patients. It shows reduced albumin. It shows raised urea. No indication of raised creatinine. Hyponatremia is indicated in hypokalemia as well. Day 3, question 1. In reference to withdrawal symptoms, why is it important to find out the type of opioid that was consumed and the last time the patient used it? Now, fill in the blanks. If the opioid is 1. Codeine, heroin, or methadone, the nurse can anticipate that the withdrawal symptoms will likely occur within 8 to 24 hours because this opioid is a short-acting, medium-acting, or long-acting opioid. Question 1, answer and rationale. The answer is 1 and 4. If the opioid is codeine, the nurse can anticipate that the withdrawal symptoms will likely occur within 8 to 24 hours because this opioid is a short-acting opioid. Codeine is the only substance listed that is a short-acting opioid, which with the corresponding withdrawal time of 8 to 24 hours. Day 3, question 2. What medication should the nurse expect for a patient who is going through opioid withdrawal? Medication: morphine, methadone, buprenorphine, or disulfiram? Answer and rationale. Morphine is not expected. Methadone is expected. Buprenorphine expected. And disulfiram is not expected. Morphine is an opiate as codeine and may create addiction. Disulfiram is appropriate for alcohol addiction. Methadone and buprenorphine are expected to help with codeine addiction and withdrawal. They shorten the withdrawal time and make the withdrawal process easier. Day 3, question 3. A patient was admitted to the hospital after she overdosed on an opioid. The patient presents with severe stomach pain and nausea, accompanied with vomiting after the 3rd day in the hospital. The nurse should suspect 1. Appendicitis, 2. Bowel obstruction, or 3. Ectopic pregnancy. Because of 4. Increased motility, decreased motility, or no change on motility. Question 3, answer and rationale. Answer is 2 and 5. Due to the presence of opioid receptor in the GI tract, a decrease in motility can occur that may lead to bowel obstruction. Opioid-induced constipation is prevalent in opioid users. Day 4, discharge. Patient presentation. Patient is alert and oriented, times 4. No signs of confusion or irritability. Pupils round and reactive. Skin dry and warm, no signs of cyanosis. Breath sounds clear and unlabored, 17 breaths per minute. Lab values within the defined limits. Well, looks like the patient is recovering pretty well. Day 4, question 1. As a part of discharge, a nurse is educating the patient about the possible risks of continual overdoses. She tells the patient that opioids cause 1. Respiratory depression, 2. Systolic elevation, and 3. Cardiac depression, which can lead to 1. Hyperventilation, hypoxia, or bradycardia, which can lead to brain damage. Opioid overdose causes respiratory depression and can also cause a secondary injury of hypoxic brain damage. Day 4, question 2. What therapies are appropriate for a patient who is going through opioid addiction and withdrawal? Milieu therapy, group therapy, exposure, or token economies? Answer and rationale. Milieu and group therapy create a positive environment with a sense of belonging and care. Exposure is contraindicated as it may put the client back to the addiction. Token economies reward the patient for good behavior but are most successful with children. Day 4, question 3. A patient was admitted to the hospital 4 days ago. She was admitted because she overdosed on an opioid. The nurse needs to convey to the patient before she is discharged that the first step to opioid recovery are professional medical care, detox, family help, and family, medical, or withdrawal management. Question 3, answer and rationale. The patient's first needs are both professional detox and withdrawal management to start the path to addiction recovery. And for the last discharge, the patient is compliant with medications, therapy, and follow-up appointments. Discharge instructions are enclosed. See separate discharge document.